Welcome to part 3 in our training series. Today we're going to talk about myofunctional therapy and what it is and what we target in therapy and what tips you can use in your therapy sessions with your clients or patients. Myofunctional therapy is an exercise based program in which we work on neuromuscular re education of the muscle function of the lips, the tongue, the jaw for the functions that we discussed: chewing, swallowing, rest posture, nasal breathing. And speech is something that we address once we complete our goals. And I don't like calling it program so much because the goals of therapy are to achieve nasal breathing, oral rest posture, correct chewing and swallowing patterns. All these exercises that we provide are a means to an end. They help us get to the end goal of therapy. And I see this happens a lot where people get lost with exercises and not realize that the exercises are just there to help us build the skills that we need for these goals. So they have to be used with caution. We have to achieve the skills to get to the end goal of therapy. So, how do you know if a client is a candidate for myofunctional therapy? If they present with these symptoms, we discussed them earlier or in the previous lesson, actually in the first lesson: mouth breathing, low tongue rest posture, tongue thrust swallow, prolonged articulation deficits. I think that if you're an SLP and you're here because you're likely stuck, stalling in therapy with a couple of clients or with one. And if they present with some disordered breathing, we typically see these symptoms together, kind of clustered. And the articulation is something that needs to be addressed once we work on the underlying concerns like mouth breathing, low tongue rest posture, and we want to understand what's going on with jaw development. We talked about how low tongue rest posture impacts on jaw development. At the end of this lesson, we're going to talk about when to determine whether or not you need to refer out to an ENT or to a tongue tie specialist or to get a palate assessed, jaws assessed for possible expansion. Who is myofunctional therapy for? It's for children who are 4 and up or children who are functioning cognitively at minimum level of a 4-year-old. Although I think that from my experience, myofunctional therapy is difficult for 4-year-olds. For this age, I would still use feeding therapy techniques, oral motor therapy. So I know that the word oral motor is sometimes a scary word in the SLP world, but when I talk about oral motor, I'm not talking about enzymes, not speech oral motor exercises. I'm talking about targeting muscle groups for chewing, swallowing, and for rest posture with younger kids. So myofunctional therapy is a type of oral motor, types of oral motor techniques. Okay, and what we're trying to achieve is not okay. Use this horn so you can round your lips for speed for a certain phoneme, a certain sound. No, we're talking about targeting myofunctional therapy goals. Okay, to address concerns about mouth breathing, low tongue rest posture, and all those symptoms that we discussed on lesson 1. So it's the minimum age is 4, but you have to know the child and determine whether or not you feel like they're ready for these exercises, if they're able to sit and follow directions with these exercises. With younger kids, I am also a feeding specialist, so I work on chewing, tons of chewing exercises. If you want to work on lateral tongue movement, right? An older child, you could teach them, you can model, you can use a mouth prop to stabilize the jaw. You'll see it in a couple of minutes. But with younger kids, we just use a chewing hierarchy to get the tongue to lateralize. That's one example that I would do with a younger child. And so it's not for toddlers, it's not for infants. With babies, we do assisted stretching. Myofunctional therapy does none of the trainings that I've taken, and I took many myofunctional therapy courses, address treating children under the age of 4. All of that I learned with, separate training, for feeding therapy and oral motor therapy, but we're just not using these myofunctional therapy exercises with infants and toddlers. Okay? Now, it is so, so, so important to address myofunctional therapy prior to orthodontic treatment. And if we don't, then the patient is going to relapse. I would say 90, maybe 95% of my adult patients come to me, and older, like teenagers, young adults with orthodontic relapse. What does that mean? It means that they had braces when they were young, their teeth relapsed. Often they come to me after they had Invisalign as an adult, so they had orthodontic treatment twice and they still relapsed. Why? Because the tongue resting low in the mouth will push against their teeth and cause them to shift. And by the way, it also happens even when patients use their retainer, whether it's a removable or a permanent retainer, teeth will shift. Talking about retainers, I just remembered something that I actually wanted to talk about when we talked about tongue thrust. There are orthodontists that still use tongue cribs to prevent tongue thrust because they know that the tongue thrust, swallow, interferes with their treatment. And I have a seventh grader who is in braces for 4 years. She had bilateral open bite, and the orthodontist was just not able to close the bite until he finally told the parents, go to myofunctional therapy. Guess what happened? We did myofunctional therapy. Within a couple of months, her bite started closing because she learned to rest her tongue in the roof of the mouth and she learned to swallow correctly. I know we talked about the tongue rest posture is what, if it rests low in the mouth, it will push against the teeth. But it's possible that her tongue was resting, kind of like her rest posture was more like in between the teeth. And she had a lateral thrust also. So I was assuming that that was her rest position. You can't see it when with an older girl who keeps her lips closed. And so once we completed the program, I hate using the word program, but once you completed myofunctional therapy, her bite closed and her braces came off. Okay, so it's really, really important to address function before braces. The other thing is braces before addressing the palate can also be a disaster because if a patient has a narrow palate and they're getting braces, there's not enough room for the tongue to rest in the roof of the mouth, and so there will be orthodontic relapse. So these are things to keep in mind when you're looking at your kiddos and you want to refer them. Here is one study that was done by Camacho et al. He actually conducted a systematic review and a meta-analysis on the impact of myofunctional therapy on sleep apnea. And this is really a quick summary. You can look it up. His conclusion was that myofunctional therapy reduced the apnea-hypopnea index by 50% in adults and 62% in children. So the way it's called the AHI index, apnea-hypopnea index, it's measured how many apneas versus over how many hypopneas. Hypopneas is reduction in oxygen in sleep, and apneas is cessation of breathing. And you get an index, and that index, the ratio is an index that tells us the severity of presence and or severity of sleep apnea. And this study actually showed that there is a reduction in AHI index using myofunctional therapy. The recommendation that was made was that it's recommended to use it in conjunction with other treatments, which means if an adult patient has sleep apnea, they should still use their CPAP. Shouldn't just rely on myofunctional therapy. But really, what we want, and I'm going to talk about it at the end, is collaborate with other professionals to optimize growth and development in children and really make sure that these things are addressed early so there's no full-blown sleep apnea as an adult. So here's an example of a skill that we address in therapy. You could call it an exercise, but really this tongue-jaw dissociation is a skill that is required for proper chewing and swallowing and for clear speech. Very often, kids come to us with imprecise articulation, and sometimes you do a, like, let's say a Goldman Fristo, and you can't like find any specific phoneme that they're distorting, but their speech is very unclear. That's because their tongue and jaw are moving together as one unit, and we need to have proper tongue-jaw dissociation for clear speech. But remember, we said that speech is the secondary when it comes to our facial myofunctional disorders. If you're going to work on tongue-jaw dissociation, you're going to get clear speech. And I'm not saying that you're not going to need to do articulation therapy at the end of a full myofunctional therapy program. Okay, so here is an example of tongue-jaw dissociation. We want the tongue to move in vertical, horizontal, and lateral movements without any jaw shifting. So up and down, in and out, and side to side without any jaw shifting. Here's an example of breathing retraining exercise. We use the pipe blows. What we want is, you see that this girl's hand is on her belly. We want to train for diaphragmatic breathing. Mouth breathing is upper chest breathing, and we want to kind of like bring it to the child's attention that the breath is coming from their belly. So put your hand on your belly, breathe in, and then blow. And we want the ball to float over the basket for sustained airflow. We could use party blowers, we could use balloons for breathing retraining. We also use buteco breathing to help our children learn to nasal breathe. And again, mouth breathing is shallow, it's upper chest breathing. We want deep breathing, and so it requires some training. So, for example, if a child had enlarged tonsils, enlarged adenoids, or both, and they were removed, not just removing them alone is not going to retrain them and teach them new habits. We need to work on these things in therapy. Dr. Christian Guilleminault, he is the father of pediatric sleep apnea, conducted research and found that children that didn't have myofunctional therapy, like he basically took two groups of children. Both groups had adenoidectomy. I don't know if they also had tonsillectomy or both. I'm not sure. I think it was both. You could look it up, Dr. Christian Guilleminault. Point is, they had their obstruction removed, okay, whether it was enlarged tonsils or adenoids. One group had myofunctional therapy, the other group didn't. And the group that did not have myofunctional therapy, tonsils and adenoids regrew within 3 years after surgery. There are some tips on promoting airway health. Activities that encourage nasal breathing are just discussed it, and breathing retraining. Diet changes. Sometimes children have sensitivities, not necessarily allergies, to gluten or dairy, and those are inflammatory foods. They can cause inflammation. So sometimes I recommend parents, and I say, you know what, this is the least invasive thing you can do. If a child has enlarged tonsils and the parents don't even want to go see the ENT, try to eliminate dairy and see what happens. If the child has excessive nasal congestion, chronic nasal congestion, try to eliminate dairy, gluten, or both, and see what happens. Using the myomunchie. The myomunchie is a great tool to help children with muscle function, with rest posture, chewing. Chewing helps develop the jaw. It's a fantastic tool. Nasal spray to clear the nasal sinuses. Also, if you're working with a child that's has chronic congestion, you want to know if a child is able to knows how to blow their nose. Just clear up the nasal passages and see what happens. So, boom boom sticks help with that. Nasal sprays, I like to recommend the Clear X. It's spelled X Clear, but it's really clear. And myotape has to be used with caution. If you know for a fact that your patient or client is not doesn't have obstructed airway, and you've worked on some daytime nasal breathing, you can recommend the myotape. If we go back to the very beginning of this training, we discussed the 5 secrets of success in treating myofunctional disorders. One of them was collaboration. We do not treat myofunctional therapy in our office and think that everything is going to change. I never ever promise parents that we can move teeth. I'm an SLP with myofunctional therapy training. I am never going to promise parents that we're going to move teeth. But very often, very young children come to me with an open bite. We work on function, the bite closes. But we really, really need to work with other professionals to optimize the success in therapy. And let's take a look at who these professionals are. The airway team is just a team of professionals that collaborates to achieve optimal health in children. SLPs, some RDHs do myofunctional therapy, occupational therapists, physical therapists, osteopath, physician, craniosacral therapist working on body alignment, dentists for those who specialize in tongue tie release, oral surgeons who specialize in tongue tie release, ENTs for airway obstruction, sleep medicine specialists. Some ENTs will do sleep studies, so you don't have to refer patients to both. I'm going to discuss that in a minute. Lactation consultants and feeding therapists are really for infants and toddlers. So when a child appears to have, I always say appear because we're SLPs, enlarged tonsils, and they have airway obstruction, and parents tell you that they have all those symptoms that we discussed, sleep disorder breathing symptoms, we want to send them to an ENT to rule out airway obstruction and to address the obstruction. So if a child has extremely enlarged tonsils that are kissing or just taking the airway space, okay, when a child opens their mouth and you ask them to stick out their tongue, are you able to see how much of their airway can you see? You should be able to see the uvula. The tonsils should be really tiny and not occupy any airway space. And if they do, then we're not going to be able to habituate nasal breathing. We can't make any of those promises to the parents without proper intervention. Some children come to us with high narrow palates. Remember, we talked about how narrow palate impacts on airway. We refer them to airway focused dental professionals. It's a dentist or an orthodontist with training, integrative dentistry, to provide guided growth appliances to develop the jaws. And these are the specialists that really help develop the jaws properly in terms of, airway and forward growth. General orthodontists use expansion that does not provide true and full skeletal growth. So we work with these providers. We work with, if you're an SLP and you're not interested in getting a specialty in myofunctional therapy, then refer out to an SLP with specialty in myofunctional therapy. If there's no SLP in your area that specializes in myofunctional therapy, then you can refer to an RDH or an OT and work with them let them address the myofunctional disorders once they're done, once the patient is done with, myofunctional therapy, then you could work on articulation. And then body work, when children get a tongue tie release, it's very, very, patients, not just children, very important to refer them for craniosacral therapy because the fascia connects the tongue all the way to the spine and it impacts on overall body alignment. And it's very, very, very important. I work with one expert in tongue tie releases that will not release a patient without proper, body work. And this concludes our 3-series training. If you enjoyed the learning and you want to learn more, I invite you to join my community of myofunctional therapists and take my course, the Myo Approach. The Myo Approach will expand on all the topics that I discussed in a much more in-depth and deep way. The Myo Approach has right now 9 instructors teaching about airway disorders, about sleep, about differential diagnosis, tongue ties. I have a PRI specialist who teaches on my course. My lessons, there's a full module on exercises and how to get a patient to carry over. And there's a whole module on articulation. The exciting news about the Myo Approach is that I am expanding the course. I have the amazing Linda D'Onofrio who's going to teach in the course. I also have Dr. David Alfie who's going to teach about jaws. Linda is going to teach about the consequences of oral motor dysfunction, and on articulation is going to be very, very specific. And there's going to be also some live training. Right now there isn't. Why am I telling you about the expansion of the course? Is because I am going to offer the expanded course to anyone that's purchasing the course right now during this launch. The course is going to be open for 5 days only, And once they close it, this opportunity is not going to come back again. Right now, the course costs $749, and there is an option for a payment plan. And you're going to pay $749, and you're going to get a course that's worth $3,000. You're going to be grandfathered in to the new expanded course if you purchase at this launch. So you have this opportunity that's never going to come back. I encourage you to join. You're going to learn how to treat myofunctional disorders with confidence and even have the opportunity to specialize and go on your own. You're going to be able to, if you feel burnt out, this is an opportunity to specialize. There is so much need for myofunctional therapy. I have people reaching out to me from around the United States and from around the world for myofunctional therapy because there is a shortage. There isn't enough. This is an opportunity for you to specialize and open a private practice. And I'm going to discuss, there's going to be bonus modules in the course. Linda's courses are going to be part of the bonuses. And there's going to be a bonus module on the business aspect of starting a private practice in myofunctional therapy. So I invite you to join me in this amazing course, join my community of therapists, and change the way you practice, and you're never going to look back. Thank you so, so much for joining me, and good luck with everything. And I hope to see you in the My Approach course.